and my specialty is in pain. My passion is in cancer pain. I have a bunch of slides we'll go through, but really with this side should be more of a conversation. So if people have questions or cases or comments, then please speak up and we can talk about them. While you're looking at my disclosures there, I'd like to acknowledge a couple of my team. I'm privileged to work with, I think, the best team in healthcare, maybe one of the best teams in healthcare. Dedicated, compassionate people. And Laura Textor is our advanced practice nurse, and Jane Stewart is my RNFA. And they're, without them, none of this would happen. And a couple of other dedicated people back home. And so a little bit about me. I started off my life as a spine surgeon, my professional life, and I headed up spine surgery at UCSF and did a lot of that until about 10 years ago I had an epiphany. And I became a little disillusioned with spine surgery, and what I was really interested in was pain. And then for the last 10 years have been focused on pain. I do plenty of spine surgery, but only the spine surgery I truly feel needs to happen because I have lots of other things to offer. And with cancer pain, I think everybody here is aware of the issue and the challenges. What you may not know is that this has actually been studied in the peer-reviewed literature. There are a number of articles looking at how well we providers do with cancer pain. And unfortunately, we don't do very well. Even in large clinics at MD Anderson and at the Mayo, it is well documented that we providers don't identify and treat cancer pain that well in our patients. And the fact is not only are people interested in this, and you can read the paper for that, but there are a number of studies showing that, never mind quality of life, it actually helps with survival. The studies on the bottom there show that if you control pain, it improves cancer survival. And when you read the literature and you talk about cancer pain, a lot of people will talk about the WHO scale, the three-step scale, World Health Organization. And I put this up here only because in this day and age, we're very focused on outcomes and quality studies and high-quality data. And what most people don't realize is that the WHO scale was created by 7 people in Switzerland in the early 80s, and they just thought it was a good idea. And that's the level of data for the WHO scale. And those references on the left there are just a few of the ones that have been done, saying that this is probably not a very good way to treat cancer pain. And it's a very linear, unsophisticated application to a very difficult problem. And that leads to the whole opioid question. And obviously, big news. And I've encountered many healthcare providers who say, well, I can get people out of pain. And that's true. You can put them under general anesthesia, and they're out of pain. That's a really bad quality of life, general anesthesia. So I see patients coming in covered with fentanyl patches, and they can barely get out of bed, and they're not processing protein, and they can't interact. And the fact is that to reframe that, I think it's really important to say the highest level of pain control with the best quality of life. You need that last clause. Because if you don't consider the quality of life with the pain control, then everybody can get someone out of pain. It's easy. And I think that what we really need to get to is the recognition that for cancer pain especially, it's a highly nonlinear, multidisciplinary approach. And we need to bring everybody on board and figure out what we're doing together. And later on I'll talk about an organization that, if you want, you can join that is focused on that. So what's this neurosurgery thing with pain? And even many neurosurgeons don't recognize the neurosurgical involvement in pain because it's largely died out over the last few decades with the advent of synthetic opioids. But the fact is that neurosurgeons were the original pain doctors. Before there were opioids, we would cut nerves and stimulate nerves and things like that. So there's really, on a high level, neurosurgeons really are involved in, can do 3 different things. So one is we can do neuroablation. That's cutting nerves, changing the nervous system, creating lesions in terms of changing the way the body processes pain. And we can modulate pain, and we can do that in two different ways. We can either deliver a drug in a small microscopic way to a certain part of the nervous system, for instance, or we can use electricity to stimulate parts of the nervous system. And those are really the three basic ways that we do things in 1,000 different ways. And the workhorse, really, for cancer pain control is targeted drug delivery, what you would call the pain pump. And that's we use that quite a bit. It's I don't know if I move over here it's a catheter. I don't know if I can point anywhere, but it's a catheter that's placed in the spinal fluid next to the spinal cord and attached to a little hockey puck pump under the skin. And we can then deliver all kinds of medications. We can deliver opioids. We can deliver other things like local anesthetics. We can get a lot of pain control that way. We can change medications. Once it's in place, it's a really powerful tool that we can use to keep people out of the emergency room and out of the hospital for pain. We can change dosing without even taking your shirt off, wirelessly. They have a remote control where they can give themselves, sort of like a PCA, called something different, where they can give themselves an extra dose if they need it. So for either refractory pain or pain that is controlled but with unacceptable toxicity, opioid toxicity, for instance, or for anticipated severe pain. I have an oncologist who would diagnose high-stage inoperable pancreas cancer, and knowing what was coming down the road, he would send them to me prior to starting chemotherapy. So we'd get it in at their healthiest, it would be healed, it would be there, and we'd have it now for a tool for their whole journey. And it's reversible. If things change, we can take it out. The procedure itself is pretty straightforward. The patient here is, we're looking at the patient's back, the head's to the right, the feet are to the left. There's a small incision in the back, a spinal tap, and a catheter is threaded through into the spinal fluid. And then usually the abdomen, but we can put it almost anywhere, we make an incision just through the skin and develop a pocket. And then we tunnel that catheter from the back to the front and hook it up to a pump. The whole procedure takes 30, 45 minutes. It's officially outpatient, although I like to keep, with people who are receiving new medication, I like to keep them overnight, and then we send them home the next morning. There is an issue with some insurance companies that require what's called a trial, and I am very honest with patients that it makes no sense for a cancer pain patient to have a trial, which is essentially doing an LP, giving them some pain medicine and saying, do you feel better? And they say yes, and then we go and do the pump. It's a little bit like giving a dose of morphine before they'll approve a PCA to show that morphine works for pain. But sometimes we have no choice and we just have to do that. The procedure is pretty low risk. You can see the risk, the potential complications there are very low. It is MRI compatible. So that's very important. It absolutely is MRI compatible. There are a few tricks with that. With radiation, the only issue is we try to coordinate with the radiation oncologists because a direct dose of radiation can really pretty much wipe out the battery. Won't cause a problem, but we'll have to replace the pump. So we try to coordinate with the radiation oncologist as far as ports. And with chemotherapy, obviously as a surgeon, we like to have the best healing environment possible. So if we can get a chemotherapy holiday or if we can coordinate with that, that's great. But with the exception of the angiogenesis inhibitors, we will treat through it if necessary. We will implant through it if necessary. Now, with the angiogenesis inhibitors, and this is from a colleague of mine, we don't do that because that's what the pocket ends up looking like. It becomes a big necrotic mass, and it's a real problem. So for those, we do require some sort of chemotherapy holiday. And this is well studied. This is a multi-centered, randomized, controlled trial. of intrathecal drug delivery versus best medical management for pain. And the clinical success there is significant. Frankly, I think in a better designed study it would be more significant, but it is significant. I think what I would draw your attention to, though, is the toxicity reduction. Again, it's opioid toxicity, and that is huge. So those patients were doing much better. They were not lethargic. They were processing proteins and not anorexic and not constipated, because those are not side effects of intrathecal drug delivery. So intrathecal drug delivery has a few side effects like swelling and things like that, but they're very few and usually easily managed. And again, this is one of those studies that did show a survival advantage. Now, this study did not achieve statistical significance because that was a post hoc analysis. It wasn't a primary endpoint, but other studies have. And I thought I'd show some of our patients. This patient, her big goal was to walk on the beach. That's what she wanted to do. And you can read there, she was really having a horrible time with pain. And like many, if you read that first sentence, I thought I was doing okay. And many patients say, a lot of time people, they don't report pain to us. And that's one of the reasons why we don't take care of it that well. Because they expect pain. They say, well, I have cancer, I should be in pain, and they don't say anything. Or they're afraid if they say something, it's going to mean they don't qualify for a trial, or they, what have you. So that's where the underreporting comes in. And some people are in such a situation, they don't even realize where they are until we get them out of pain. And that's her walking on the beach in Hawaii with her pump. And she passed away shortly thereafter. Another patient, and this is another issue. The number one feared consequence of cancer is pain, not death, if you actually ask patients. It's the number 3 symptom after anorexia and fatigue. But this patient, we were able to get control. Just an aside, a little trick with vulvar cancer for palliation is if you put 0.75% bupivacaine in a little mister bottle that you get from Home Depot, then you don't have to touch to apply it. And so a lot of patients, to put on the local anesthetic, you have to touch, and it's really excruciatingly painful. So if you use a mister, and if that doesn't work, add a little fentanyl to it. So the other area is using electricity, neurostimulation. And we can do that in a lot of different ways, pretty much in anywhere in the nervous system. We can do it in the spinal cord is very common, in peripheral nerve, and even the deep brain stimulation. And by applying electricity to the nervous system, we change the way the nervous system processes pain, and we can often improve the pain perception. Now with cancer pain, this is mostly in a survivorship scenario. And it's very good with post-intervention pain, because oftentimes that has a significant nerve kind of pain component, neuropathic pain. Chemotherapy-induced neuropathy, radiation-induced neuropathic pain. And post-surgical pain often is the same thing, such as in post-mastectomy, post-thoracotomy. Those are excellent scenarios if they're refractory for neurostimulation of various kinds. The other scenario could be when a nerve-type pain starts to dominate the clinical picture, such as the patient we had who had a contiguous prostate cancer into the ischium. And we had him in good control with an intrathecal drug delivery system until that ischial mass started to directly involve the sciatic nerve, which gave him horrible sciatic pain. And then we started to drive up the pump up and up and up for this one area of pain. And that would be the kind of scenario where a neurostimulation might be able to take care of the nerve pain and allow us to then bring the pump dose back down to treat the other areas. So now I'll switch to neuroablation. And that's the area that we neurosurgeons do, where we create lesions in the nervous system to deal with pain. The best review, each of you has a USB drive, and that's not just swag. I loaded every reference in here is on that USB, plus a few others that might be of interest. So So you might look at that later. But this is still a friend of mine, Ahmed Raslan from OHSU, very experienced, excellent neurosurgeon. In 2011 wrote what is still the best review of this field in terms of the whole breadth and depth of what we can do with neuroablation. And that's on there. The issues with that is, one, it's irreversible. So we can't, like with a pump, change it or what have you, or with neurostimulation, trial it. We do it, it works, it doesn't work, and that's pretty much it. The other is we don't know exactly how long of a duration it will give us, which is why it's not really used for chronic pain, it's used for cancer pain. And we'll talk a little bit more in detail about that. And we also there's some debate about whether it's good for nerve pain, neuropathic pain. Many of us think it is, some don't. We're still working that out. But it is can be a very good technique for cancer pain. I would say that none of the statements you might hear about the procedures are based upon modern data. Because we're resurrecting this and we're applying new technology to old procedures, basically everything that you'll hear from perhaps an older neurosurgeon or whatever is based upon literature that studied procedures that we no longer do. So we're going to talk in a second about chordotomy, and we do chordotomy now through a needle, but all the literature is based on open chordotomy, or almost all of it, which is a completely different procedure with a very high complication rate. So I just urge you, if you hear of things, to make sure to ask yourself, is this about the procedure we're doing today, or is it about a historical one? And don't worry, we're not going to go through every one of these, but this is a list of the majority, probably, of neuroablative kind of techniques that we can do in the various scenarios for different types of pain. The chordotomy is one of the most powerful, simplest procedures that we have for cancer pain. And conceptually, the spinothalamic tract in the spinal cord is what carries pain and temperature. And we go in with a probe, awake, under local anesthesia, in a CAT scan. We find that, and we turn it off with a radiofrequency ablation. That's the idea. And that's really good for any pain on one side of the body below about the shoulder, C4. And it doesn't matter where it's from, why it's there. We could do it bilaterally. We're going to talk a little bit about that. So it could be bilateral pain, like bilateral hip pain. The issue of nociceptive pain, which is the kind of pain that the body uses to protect itself, like a broken leg or a sprained ankle or a burn, versus neuropathic pain, which is nerve pain, which is from abnormal nerves sending abnormal signals to the brain. And again, there's a debate in neurosurgery about whether this works for neuropathic pain or not. But it can be exceedingly effective. And what we're doing, this is the spinal cord. The red are descending motor, and the blue are ascending sensory tracts. And what we're going to find is the spinothalamic tract, which is right there in the anterolateral quadrant. We're going to find that with a probe. So we put a small 20-gauge needle. It's essentially like a C1-2 spinal tap gone horribly wrong. So we put a spinal needle in the spinal fluid, and then through that we put that tiny probe into the spinal cord. You can see the positioning there on the right. It's done with a myelogram, outpatient, local anesthetic. Patient's awake, and we use stimulation to make sure we're in the right place. So not only do we look at the anatomy, but we stimulate. We make sure that there's no motor stimulation. We use a higher frequency to look for sensory, and they say, yes, I feel it on this side, and then we create our lesion. It has an exceedingly low complication rate. I hate saying that, but it does. And that's what it looks like. That's a myelogram. The nose is up and the back of the head's down. This is at C1-2, and you can see that needle coming in from the right-hand side there, and through that you can sort of sense a little tip right in the spinal cord. Now, this is what you may read about in terms of the complications of chordotomy. These are essentially historical. So there is this issue of mirror pain, where you might have a patient with pain in the right side and they could get some pain in the left afterward. I've seen that a couple of times. It's usually mild and easily handled with gabapentin or something like that, and it tends to go away. The others, sensory motor deficit, I've never seen. None of my colleagues have with the modern technique. Ondine's curse is with a bilateral chordotomy, and it is terminal sleep apnea. So you go to sleep, you forget to breathe, and you die. That's Ondine's curse. It's really horrible, and it requires a permanent tracheostomy. No one that I know of has ever seen that with the percutaneous technique. It's talked about all the time with chordotomy because it was in the literature with the open technique, which was this horrific open thing where we tear things open and see the spinal cord and cut it and hopefully we're in the right place. And so I would argue that until we actually find that's probably not the issue. We talked about the efficacy for neuropathic pain. Now, as far as the duration of response, the neurosurgery board's answer is about 2 years. But again, that's based on old data. And the fact is a colleague of mine just reported a 4-decade response to chordotomy, and he came back just wanting to have it repeated. So we don't really know. It's certainly for people with less than normal survival, it could be a good solution, and it can be repeated. The outcomes are really pretty good. And this is Dr. Kampelat's study. He has the most, he recently passed away. He has the most experience in Turkey. 207 patients, 14 of them were non-malignant, 92% success rate. He had 12 bilateral cases in this, no instance of Ondine's curse. And this is a young man who came to us, went to work, got out of his truck. As soon as his foot hit the sidewalk, his femur broke, went to the hospital, huge synovial cell sarcoma with mets to the lungs. And when I met him, he came in a huge brace. He was on continuous IV Dilaudid, and he would only get out of bed to see doctors. Recently married. And we talked about a pump, but he had just started chemo. He didn't want to go off of chemo. It was the only hope he had. So he came in and he had a chordotomy. Yeah, it was very articulate actually. He said he felt this bzz in his head, and then the pain went away, just like that, like a light switch. And when it's successful, like it's really successful, just like a light switch. And that's, my OR staff loves it because they literally on the gantry, out of pain, everyone's crying, and I mean, he walked out of the hospital. And he continued to walk on that tumor for the remainder of his life. I think he lived another 3 or 4 months, but without medicine. A different approach, midline myelotomy, is for abdominal, visceral, sacral, pelvic pain. Pancreas, liver, sacrum, retroperitoneum. And this is through a different pathway that is largely not taught in medical school, certainly wasn't taught in my medical school. That is in the medial aspect of the dorsal columns. So this is our spinal cord, and what we're talking about is right there in purple. And that carries pain from the abdomen. And we can interrupt that with what's called a myelotomy. Now that's an open procedure. So you can see here's the spinal cord, that's the dorsal surface of the spinal cord. And you can see on the right-hand side there is an instrument. The pia has been opened, and we're creating this lesion up and down the spinal cord. That's an open procedure. Pretty good data on this. Not as good as chordotomy. Still can be very effective. I suspect that the quality of the data is less good because of the heterogeneity of the populations. And if we did studies, and we should be doing studies, with a more homogeneous population, we would probably get a better outcome. But it tends to be very safe, and there is a percutaneous way of doing it. This is done at the occiput C1. This is a patient with a myelogram, face down, the nose is down, and the needle's coming in the back of the head, and you can see the needle there, and then the probe goes right through the middle And we stimulate, we get stimulation on both sides, the patient reports that, we create the lesion. This was a patient with recurrent pancreatic cancer. She went, you can see there, from 180 to 300 milligram morphine equivalents a day to 10 to 20 milligram morphine equivalents a day. The difference is that I'm not sure, I don't think this is quite as efficacious as the chordotomy. There are more patients who we have this that are not successful, and then we can consider going on to the open procedure, which is a small laminectomy, but it is an open procedure. I'm going to go through Dres lesions very quickly, but this is essentially interrupting pain as it comes into the spinal cord along the dorsal nerve roots for usually arm pain, brachial plexus, things like that. And the area we're talking about is right there on the right side. Didn't quite make it. That's not what I'm looking at. Huh. There it is, right there. So that's where the nerve enters, the dorsal root enters, and we can interrupt that for usually brachial plexus pain. This is an open procedure, and you can see here the instrument coming into the side of the spinal cord, creating those lesions. We do multiple lesions. And this is for things like a Pancoast tumor or a neoplastic or radiation-induced brachial plexopathy. The classic non-malignant indication in neurosurgery is a traumatic root avulsion. For facial pain, one of the nice things about the way the nervous system is organized is when the trigeminal nerve brings in facial pain or sensation, all of the non-painful sensation goes straight up, and all of the painful sensation goes down and then comes back up. And we take advantage of that in neurosurgery. We can interrupt those pain pathways for head and neck pain. This is an open procedure. It's essentially that Dres procedure done higher. And you can see on the left-hand side here, that's the cerebellum. This is the posterior inferior cerebellar artery. This is the brainstem here. And this is the instrument coming in and creating that lesion there along the nucleus caudalis is what it's called. Click. There we go. And you can see here, this is a schematic showing how those pain fibers come down, and we can actually intercept them with a needle right there as they come down to the nucleus caudalis there, which is what processes facial pain. This is a picture of that percutaneous procedure. On the left-hand side, the patient is facing to the left, and that's a needle. She's awake. That's a needle going through the foramen magnum and into the brainstem. And we can stimulate that, and we can ask her where she feels it. And there's an endoscopic picture on the right-hand side. At 12 o'clock, you can see that silver is the actual 20-gauge spinal needle. And going through that is a black probe into the brainstem. The cerebellum is between like 12 and 2 o'clock. And so we can stimulate that. And that, for instance, we had a patient with a glossopharyngeal cancer. She couldn't eat. It was too painful to eat. So we could do this procedure, and then she could go ahead and get enough relief where she could eat and drink. And that's, again, a small needle. We don't have to heal a wound or anything like that. Hypophysectomy. Now, most people look at this 3 times because this is actually taking out the pituitary gland. And it's been done for a long time. It was originally done open. There are case series from the 70s of hundreds of patients. Breast cancer, prostate cancer, for diffuse, usually osseous metastatic disease with pain. And now we can do it with radiosurgery. And Dr. Chetty and I were talking about this last night. So we can basically do the same procedure with a radiosurgical hypophysectomy, and it can be very effective, outpatient, non-invasive, for diffuse osseous pain. There are neurosurgeons now using it for diffuse non-osseous pain, metastatic pain. I don't have any personal experience with that. But this is a patient who came to me, 80-year-old man, very nice man, had Mets from basically the vertex to the knees and diffuse pain. Now, that's not something I can do with a pump because it's not regional. I can't get to one area. It's everywhere. So we did a radiosurgical hypophysectomy. And he started off taking, you can see there, 500 milligram morphine equivalents a day with 10 out of 10 pain. He came in one Friday. He had 150 gray to the pituitary, went home. We did this on a CyberKnife. And over the next 4 days, you can see he went down to 200 milligram morphine equivalents a day with 2 out of 10 pain. Very effective. We don't know why it works. We have no idea. It started off with the hypothesis that it would be an endocrine issue, and they started with breast and prostate cancer. And then they found out that it didn't really matter whether it was an endocrinologically active tumor. It still worked. So we don't know why it works, but it does work. And then anterior cingulotomy is limbic system. We can actually operate on the limbic system of the brain. This is done through 2 small burr holes in the skull. Very little invasiveness, and but it's neurosurgery. And this is a known procedure in neurosurgery for depression and OCD. It's done a lot. But it also works for pain, and mostly is done for cancer pain. And you can see there have been case series of this. The interesting part about it, I find it fascinating, is it seems to work on the affective component of pain. So patients will tell you that they still have pain, they don't suffer from it as much. And we had a patient where he had diffuse Mets, I forget the primary, and he couldn't even be moved. They couldn't move him to change the bed without him screaming in agony. And we tried some other things, but we did a cingulotomy on him, and he went to like taking a hydrocodone, and he would still yell out when they moved him, but then he's okay. He'd be all right. And my hypothesis is that there is an obsessive component to severe chronic pain. That people they're worried. I'm going to be in pain. I'm in pain. Will I ever be out of pain? Is it going to go away? And that seems to be treated with this. Very successful. And this can be basically any pain, anywhere in the body. I put down there at the bottom, just because I thought it was interesting, a case report recently, a couple of years ago, where they used this for air hunger. So there was end stage, I think it was a mesothelioma, and they did it for the pain, but then they found that the air hunger was also treated with the cingulotomy. There we go. And that's what it looks like on an MRI scan. So I thought I'd go briefly through a few common things we see in the clinic. We all see pancreatic cancer, one of the very painful situations. And this is sort of how I think about it. Our workhorse is intrathecal drug delivery, the pain pump for pancreatic cancer. It's scalable. We can turn it up, change it, things like that. But if for whatever reason they can't have a pain pump, let's say they have ongoing infection or other issues, then we have myelotomy. For short term, maybe a few months, we could do a celiac plexus block, or perhaps to get them through their chemotherapy and then put a pump in once we have a chemotherapeutic window. And then, of course, cingulotomy, which will be throughout all of these. Head and neck cancer. Again, pain pump. We can put the catheter all the way up into the foramen magnum for facial pain. And it can work. It doesn't always work, but it can work. But if not, we have the trigeminal procedures, the percutaneous nuclear tractotomy, the open nucleus caudalis DRES. We now are starting to do, a colleague of mine in France is starting to do intraventricular drug delivery for both head and neck and diffuse pain. Same pump, same catheter, now we're putting it in the ventricle of the brain, endoscopically, right over the thalamus. And he has published a case series, which is on your USB drive, that's really interesting. And of course, cingulotomy. Multiple osseous metastasis, depends. If it's regional, I'll still think about the pump. If I feel like I can get that region with a catheter. But if not, the hypophysectomy we talked about, intraventricular drug delivery is something that they're starting to do for that. And for the DRES, for the apical tumor, apical lung tumor, brachial plexus, if the arm is functional, then we can't do a DRES, or we shouldn't do it, because that can actually disrupt function. If you don't get the sensory input, you're not going to know where your arm is in space. It becomes essentially non-functional. But if the arm is functional, intrathecal drug delivery, chordotomy perhaps, depending on how low the pain is. If it's not functional, a DRES lesion is good. And basically every case is complex, but I wanted to bring a case that would illustrate sort of how we go down this path with multiple modalities. We had this patient come in, elderly man, left upper lobe non-small cell cancer with chest wall invasion, bad pain, and I put in a catheter, an intrathecal drug delivery system, got great control of the chest pain. But on the right there, you can see he had an S1 metastasis. And there's also another little metastasis below that near the coccygeal segments. And he had this horrible sacral pain, and he could not be weight-bearing on his sacrum. Every time we tried to even sit him up or stand him, he was in horrible pain. And we spent actually weeks in the hospital playing with his pump, trying different things. We could not get this because the catheter tip was too high for the sacrum. So we took him to the operating room, and we did a myelotomy. And you can see we've moved the catheter to the side. That's the catheter there next to the spinal cord. Did the myelotomy. And within 24, 48 hours, we got him up. We got him walking around. He was sitting, and he went home. And he ended up living another 6 months, I think, at home. So that's the kind of thing that we can do where we go down the pathway with the patient. And we do things as they come up. And we try this, and we try that, and whatever is appropriate. And in fact, a few colleagues of mine and I got together and wrote these cases up of how to combine these modalities. So a few years ago, being frustrated with the lack of coordination with all the different disciplines that touch cancer pain, I started this organization. It's a now international nonprofit. There's several hundred members. It's open to physicians, to advanced practice providers, to really anybody who has an interest in cancer pain. I would invite all of you to come join us. We have an annual meeting. I don't know where the next one is. But now we have centers. We have most of the cancer centers in North America have teams that are members from different disciplines. We have a number in Europe, few in China, a couple in South America, and just recently the Australians applied to start a chapter. And this is in your folder, but we got together with Patient Resource, which is a patient education company in oncology, and we put together this cancer pain guide. It's a patient-focused guide. It's a multidisciplinary editorial board. It's available for free to patients. You can download the PDF. There are print copies, and in fact, this is what we do with the Center for the Relief of Pain is for a very reasonable cost. I get none of this, so this isn't me, but for a very reasonable cost, they will brand it so that they'll put the CCCC logo or something, and you can hand it out to patients. But it really, you should look through it. It has pretty much everything a patient needs to know about what their options might be. So I don't think that anyone here needs convincing that cancer pain is important, but it is undertreated, and it has more impact than just the obvious in terms of perhaps survival, compliance with treatment, and that there are many, many options. And it's important for patients to understand what their options are, to have the opportunity to talk about what their goals are and how it fits into their treatment, and to try to decide what is appropriate for them. And that's what we're about. We're trying to offer those options to as many patients in pain as possible. So thank you for your attention. I'm happy to entertain questions or...
Some of the worries we have...
I have a question.
Yes.
Can you hear me?
I can.
Okay. On the targeted drug delivery, the pain pump, you say you can't. Is it contraindicated to use angiogenesis inhibitors with those? Is that what you were saying?
I can't put it in with angiogenesis inhibitors. So if they're on an if they're actively taking it, we need them to have a holiday to put it in and get it healed, and then there's no problem with taking them.
Okay.
But yeah, it's just the wound healing issues.
Sure.
I have
Good
a question. I have a question. What about if they receive radioisotopes for pain control? How long do you have to wait so that you don't contaminate your pump or so forth?
Wait between giving the isotopes and putting the pump in?
Well, or, I mean, if they've received them, it's received the, let's say, whatever isotope for pain control, and do you, I mean, does it matter that, I mean, as to time, even a PET scan, I mean, do you want to wait to do the surgery, so forth?
I honestly don't know. I think I would ask you.
Well, for a PET scan, that's an easy question, I would definitely, they say 4 hours, but I wait a day. But for the others, depending on the isotope, I think that I would wait, until you have enough, I mean, all of it basically delivered, and then see. Because I think otherwise you're going to have issues with contamination.
Right. And that, I mean, so that's, for me, that's a radiation physics question that I don't know the answer to. So it would be a safety issue. Also, if somebody's had an intervention, we want to see if that is going to work before we go on to the next thing, perhaps. I mean, it's medicine is complicated, and there might be scenarios where we want to just do it as quickly as possible. But I probably would say, well, okay, let's see the effect of that treatment and then deal with whatever's left over.
Something else is, this is not as dire as cancer pain, but we do have a lot of people with really incapacitating post-herpetic pain. Do you have any advice?
Yeah, we see that quite a bit. That's a neuropathic pain, and basically the neurostimulation can be very effective for that. There are also, depending on the location, like thoracic ganglionectomy can be effective for that, which is a small procedure, a small surgery. But typically we would start with neurostimulation. And we just had a patient coming back with, he had a post-herpetic neuralgia, I don't know if you can see me, but right on the chin. It was actually a Nebraska police officer. And we put in leads just under the skin in that area. And he just came back, he's 7 years out, and he just wanted his battery changed. It's a hard, post-herpetic neuralgia is a hard thing. And we have things, the new Qutenza, which is the high dose capsaicin that has to be given in the office. So Laura does that. And so that's an option for them as well, depending on how much surface area we need to cover. But yeah, we do have options for that. It's just not, I probably wouldn't use a pump for that, for instance.
Okay, thank you.
You had a question.
So many of our cancer patients are smokers, they don't take care of their teeth, they have infection risk. Do the pumps get infected, the sockets get infected?
They can. I mean, it's not, it's really the placement of them. And they're not prone to it's not a vascular implant, so it's not like an ongoing thing. But if there's one of the relative contraindications is active ongoing infection to the placement of the pump. And that's, I say relative because, let's face it, we deal with patients in very difficult situations. And if we waited for them to be perfect, we would probably not do anything on anybody. So a lot of times we weigh this and say, what's the risk? But that might be a situation where we say, well, let's do a cordotomy. We'll get them out of pain or get them out of the hospital, get them healthier, and then we'll see, maybe we'll come back and need to do a pain pump 3 months down the road or something. Well, thank you for having me, and take a look at the materials. If we can be of help, I'm happy to hear from you, and take a look at the articles on the USB drive. I think they'll be very interesting for you.
Getting our people to you is somewhat of a challenge. Sometimes their insurance is Blue Cross that doesn't go to Kansas City. Sometimes it's transportation issues for many people.
Well, we do. I would say that we are set up for telehealth. So we've done a few of those and love doing those because then patients don't drive 6 hours to discover that they're not interested in whatever we have to say. So that's a good start. We do have the dedicated nurse navigator at research for Sarah Cannon. That's the same. All you need is the one number to get there. I have my cell phone for anybody who wants it, and I'm happy to hear from you if you have questions or a hard, difficult case. Laura, Jane, we're all we take this as sort of our mission. So we want to make it as easy as possible for your patients to get access in whatever way we can.
Thanks for doing that.
Sorry. Thank you.
Thank you.